Step-by-step examination cardiovascular system. For this, to begin with, we do a general survey of the patient, and we start from the face. We look for pallor, then we look at the tip of the nose, ear lobules for any cyanosis, then the lips, the tip of the tongue, and then we go on to the hands. We feel for the see for the pallor. We look for any clubbing by coming at the level of the patient, and we feel for any tender nodules in the pulse. It's called Oestrogen nodules, and we look for any Janeway lesions on the palms, and then we feel for the pulse. We compare both the pulse, and we can check for radiofemoral delay. And if need be arise, we look for any collapsing or water hammer pulse, like that. And then we come to the chest. We closely look for any scars, especially in the intercostal space on the left side, for any mitral valvotomy. We look for any pulsation on the precordium, and then we look for the apex beat. Then we look for any pulsation in the epigastric area. Look at the neck veins. But for this purpose, we have to make the patient at an angle of 45 degrees. Then we go on to the foot end of the bed and look for the movement of the chest. Look for the chest itself, whether it's symmetrical or not, and see any abnormal pulsation. Okay. Now we move on to the palpation of the precordium. Make sure that your hands are quite warm, and then you place the palm on the precordium and feel for the apex beat and feel for its character, whether it's heaving or it's tapping. And once you have felt the maximum impulse, put your index finger vertically to localize, and then you can measure it from the mid-clavicular or mid-axillary, or whether it is displaced or not, or whether it is in the normal position. Then you also feel for any thud or pulsation, and any pulsation in the epigastrium. Now we move on to the auscultation. For auscultation, it is very important to time the murmurs with the carotid. So put the thumb of your left hand at the middle of the carotid cartilage and the middle of the anterior border of the sternomastoid muscle on the right side, and feel for the carotid pulsation. And with the help of the stethoscope, you feel for the mitral area, then for the tricuspid area, then for the aortic and pulmonary areas. During that, you ask the patient to take a deep breath in and hold it in expiration or inspiration to know the effect of respiration on the intensity of the murmur. Afterwards, you use this bell of the stethoscope and turn this patient on the other side and look for any or hear for any murmurs, and also for any radiation to the axilla. Then you ask the patient to sit up and instruct him, because you are going to listen for the murmur of the aortic regurgitation. Ask him to take a deep breath, slow, and breathe out, saans bahar nikalo, and then you listen for the early diastolic murmur of aortic regurgitation. Auscultation of carotid is an important part of cardiovascular system examination. For this purpose, we ask the patient to flex the neck a little bit. First of all, feel the carotid one at one time. Never feel both carotids at the same time. Put the stethoscope middle of the anterior border of the sternomastoid and ask the patient to hold the breath so that the breath sound should not interfere. And listen for any carotid bruit. And listen on both sides to compare. Examination of the cardiovascular system is not complete unless and until you auscultate the lung bases as well. So when the patient is sitting up, you can do two things. Check the blood pressure while the patient is sitting up. At the same time, you can listen at the bases of the lungs for any collection of fluids or any basal crackles. And at the same time, you can look for any sacral edema by pressing the thumb on the sacrum. You can ask the patient to stand up and can note down any postural drop in the blood pressure as well. While during examination, when the patient was lying, you could do you can compare all the peripheral pulses, you can feel the peripheral pulses, and you can look for any calf tenderness, for any evidence of DVT, which can affect the cardiovascular system later on, and you can also note for any pedal edema. And you can also have optional fundoscopy to see Roth spots in the retina if you suspect a patient suffering from infective endocarditis. Look at the jugular venous pressure or JVP. For this purpose, it is important that the patient should be positioned at an angle of 45 degree, and this angle of 45 degree should be at the hip and the trunk, not at the neck or the upper part of the chest. Now, just slightly tilt the patients on the opposite side and see if there are any engorged neck veins, especially the jugular vein, and see if there are any pulsation or not. And look at the tangent to see that they become more prominent when the light shines from the opposite side. And you can also check the level. For this purpose, you can first of all feel the sternocleidomastoid joint and put a ruler vertically on that, and then you note down the upper level of the jugular vein, and then you place another ruler or a wooden spatula at right angle to the vertical ruler, and then you note down how much high is this height, and that will tell you the jugular venous pressure. At the same time, you can perform hepatojugular reflux by pressing the liver area with your hand and look whether there is any change in the level of the JVP or not. And sometimes you can also obstruct at the supraclavicular area the JVP level, whether it becomes prominent or it has any effect or not. Look for the signs of cardiac failure. For this purpose, we lie down the patient at an angle of 45 degree, as I told you before, and we look at the JVP. Then we feel for the upper border of the liver by percussion, and then we feel the lower border of the liver as well, whether this patient's liver is displaced or he's got hepatic enlargement. And we feel for the surface, for the tenderness, the margin, whether it's smooth, rough, etc. And then we go on to the back to listen for any basal crackles. Then we look for edema at the sacral area, and we look for edema at the tibial area. And we conclude whether this patient is in